Hello and welcome. I'm Dr. Anthony Gonzalez again here with Miami Community Health, again with another important health topic. We're going to talk about the gut today, the intestines. We're going to talk about the bowel. And what better than to bring you a gastroenterologist, somebody who specializes on bowel and intestines and everything inside your tummy, than a gastroenterologist, my friend and our gastroenterologist, Dr. Pedro Llaneza. Welcome, Pedro.
Thank you very much for inviting me. How are you?
All right. I'm doing great. Great.
Good.
So tell our viewers a little bit about yourself. What do you do?
I'm a gastroenterologist. I'm in prior practice in Miami. I've been so for about 37 years. And I do general gastroenterology, even endoscopic procedures and the whole thing that a gastroenterologist usually does.
And the common things, we're going to talk about one particular topic,
right.
but the common things that people see you for are what?
Abdominal pain, IBS, probably one of the most common things that I see. And this is IBS Awareness Month.
Yeah.
And that's the reason we're going to talk about IBS today. But other things like ulcers and, alterations in their bowel habits, like diarrhea and constipation, and sometimes the liver test abnormalities, that kind of thing.
Wow. Okay. And of course, everybody has to see their gastroenterologist because everybody needs a colonoscopy.
Correct.
Right. So you have to see her.
45 now.
Yeah.
Before it used to be at 50. We just decreased the age for screening colonoscopy to 45. Some new changes in those criteria.
Wow. So your gastroenterologist is very important, no matter whether you're a woman or a man. Gastroenterologist is very important. You just need to see your gastroenterologist for screening colons. But we're going to talk about a condition that, as a surgeon, I don't know a lot about. I don't understand. I don't even know if I believe in. So we're going to talk about irritable bowel syndrome. Irritable, like, when you're irritable a little bit and, somebody's making you annoyed. Irritable bowel syndrome. So what is it first?
Well, it's a syndrome. It's not a disease. So I should point that out because most people equate irritable bowel syndrome as a disease when it's really a syndrome. As you know, syndromes are a group of symptoms put together that define a certain condition. It's not a disease because we can't quantify it. We can't do a biopsy like a cancer and biopsy a mass and it's cancer. It's cancer. That's a disease. We can see an ulcer in endoscopy. We can measure your blood count and tell you have anemia. So all those are diseases. Irritable bowel syndrome is a syndrome by which we put together a series of symptoms and we say, oh, you have this as a doctor. But what's interesting about irritable bowel syndrome and why there's a IBS Awareness Month is because it's actually the second most common cause of absenteeism from work in the United States. Number one is common colds. So people are more absent from going to work. Second most common cause is IBS.
Wow.
And so it's a huge amount of people that are affected by this. And at least 1 out of 8 persons in the United States have some form of IBS, of course, varying degrees of intensity or how bad it could be. In the United States, the predominant person that has IBS are women. So there's a ratio of about 10 to 1 women with IBS in the United States. That's not true for the rest of the world, though. There's some areas in the world like Nepal and India and some other areas where it's 5 to 1 men. So we don't know why that is, but it definitely occurs mainly in women in the United States.
All right. So we understand it's a syndrome. We understand it's a constellation of symptoms.
Correct.
What are those symptoms?
All right. So it was recently defined that there's a group of criteria by which most doctors should. You can make the diagnosis of IBS nowadays. Come on, you're a surgeon. You can do. You can do this too. It's actually was made simple by a group of experts about 30 years ago. After a conference on IBS, they got together. The conference was in Rome, and they said, "Well, there's really no way of diagnosing this." So they got together and set a series of criteria. All right, so they quantified or qualified these criteria, and there's been 4 revisions. We're now in what we call the Rome Criteria 4, so that any doctor or person can self-diagnose themselves. So they made it very simple. And basically what it is if you have abdominal pain or discomfort at least once a week, 1 day a week for the last 3 months. And those are those patients who have discomfort or pain are associated, these pains are associated with change in defecation, change in the form that you have a bowel movement, or if the pain is relieved by the bowel movement. These simple criteria is enough to suspect you may have IBS. Of course, in order for you to make sure you have that and not something else, you have to exclude people that have a family history of Crohn's disease, or if you have a personal history of rectal bleeding or weight loss, or if these symptoms, this constellation of symptoms like you mentioned, start after the age of 50. So if you start having these symptoms at 52, 53, that may not be IBS. And then you should raise a little red flag and go visit a doctor. But like I said, they've made it so simple so that the general population can self-diagnose with IBS because it's so common and so frequent.
But these symptoms are abdominal pain and change in your bowel habits. And it's once a week, but is that
for 3 months?
For 3 months.
Mhm.
But is that related to eating or not related to eating, or
Not-
doesn't make a difference?
No, related to eating doesn't make a difference. Related to eating is a little different form of functional bowel, which is what's called functional dyspepsia. So it's a little bit different. But IBS itself has to do with defecation and changing your bowel habits. So having diarrhea, for example, associated with some abdominal pain, or relieved by diarrhea, or being constipated and bloated, which causes that discomfort, and change in your stool caliber. These are all things that are parts of the symptoms we look for to make a diagnosis of IBS. And people can treat it themselves, and if the symptoms improve with their own treatment, then that kind of confirms the diagnosis to themselves. So I don't want people to think, oh my gosh, this is such a specialized diagnosis that I can't make my own diagnosis and treat myself. No, we want to encourage people to make their diagnosis on themselves first and treat themselves if they don't feel any better, then of course seek appropriate medical attention.
But don't we want to first make the diagnosis? Is there a test? So if I've had this discomfort, I'm listening now, do I have to go get a test?
No.
There's no test.
There's no test. Not even if I'm an expert. There's a test when you have warning signs, or what Rome criteria call alarming signs or symptoms. The alarming signs or symptoms, again, are bleeding, very important. If you have any bleeding, that's never IBS. So it could be something simple as a hemorrhoid, for example. But if you see blood with a bowel movement, with your stool, then absolutely not IBS. So if you have rectal bleeding, that is not IBS. You need to seek appropriate medical attention. If you have weight loss, unexpected weight loss, if you have other alterations in laboratory testing, like if you have B12 deficiency or et cetera, those are things that are alarming signs. So no, there's no specific test to check for IBS. Like I told you before, it's not a disease. It's really a syndrome. Right? So if you got the right symptoms, you exclude the alarming signs, make the diagnosis of IBS. Even if you're a doctor, by the way. And in the old days, we used to call this a diagnosis of exclusion.
Yes, I remember that.
Remember that? So,
yeah.
So you have to exclude this, and that. Well, that's been put aside by the Rome criteria. We want doctors to make the diagnosis right off the start based on these criteria so that you don't incur in such expensive workup. By the time that I see patients with IBS,
they've had $1 million workup.
Yeah, right. But most of the time, people do the right, make the right decision and make the.
Well, what you're telling me indirectly is that you want people to make the diagnosis, whether it's even self-diagnosis or you want a doctor to make a diagnosis, because there's got to be good treatment.
Yes.
So what is the name of the pill that I take to cure IBS?
There's none.
Oh my.
Okay. So you use, but you can use very common sense.
Okay.
Right? So if you're constipated, you start by treating constipation with fiber. It's the mainstay of constipation. You increase your fiber in your diet. You can, off the internet, you can get 1,000 diets which increase fiber. But you can also supplement fiber. There's different types of fiber, of course. Then we get a little bit more technical into hydrophilic and hydrophobic fibers, etc. I don't mean to confuse people, but hydrophilic means that it attracts water, other ones repel water. So
right.
the different types of fiber, and which one agrees with every person. There's not one fiber for everybody. There's no such thing. And a lot of the research that's been going on in more recent years, Tony, is the research in the intestinal flora. So it's so interesting. To me, it's fascinating.
Well, explain to people what flora is, because when I tell people, after we give them antibiotics for surgery, they have some diarrhea and they didn't understand. So explain to people, how we live in this homeopathic, relationship with bacteria.
Well, it's so to put it in perspective, a human body on average is about 13 trillion cells, right? So out of the 13 trillion cells, about 9 trillion live in your colon, because stool, okay, by weight is about 70% bacteria. So a piece of fiber that you don't absorb, humans don't absorb fiber, 1 billion or 2 billion bacteria stick to that little piece of fiber and they eat it up and they reproduce by the second forming stool. Well, the type of bacteria or flora means there's different types that predominate, that will dictate the type of stool you have, the amount of gas you produce, and the type of gas you produce. When bacteria that are irritant to the colon predominate, then you tend to get an irritated, quote unquote, a colon. There's no such thing, but that's where the word irritable bowel comes about. So we do know that there is tremendous amount of what we call technically dysbiosis, which means alterations in the intestinal flora or the different types of bacteria that predominate in the colon, basically. So a lot of the research done today on IBS has to do with that flora you're talking about. So yes, we give somebody antibiotics, you alter that flora enough that sometimes may cause diarrhea and
right.
more
So we were
problems.
talking about the treatment for IBS. So let's go back to the treatment. So the treatment is, if you have constipation, you take a fiber or stool softener,
Correct,
right?
Correct.
What are the treatments?
Try to avoid the stimulant laxatives. You can.
Okay.
So there's a number of non-stimulant laxatives that you can use. Fiber certainly is the mainstay. Like I said before, you can use things like commercially known as Miralax, is glycol. I don't want to mention the commercial names, but that's a commercial
That's okay.
name.
You can mention whatever you want here.
Yeah, I mean, it's just the easy one. And that is not a stimulant. That doesn't hurt anything. It's really almost very innocuous.
Okay.
Unless you have an obstruction, that's a different story. But if you don't have an obstruction, it's very easy to use. Now, if you need something beyond that, there's a series of new laxatives. What I call new because it's a whole group of laxatives that are by prescription, but also have a very innocuous, meaning a very safe profile, because they don't stimulate anything, they don't really hurt much, they don't interact with other medications. But those are by prescription. But for that, you have to go to the doctor at that point. You could use some stool softeners. The problem is most patients, their body sort of get used to a stool softener after 3 months of using it. So what usually happens is start taking a stool softener. It works well 3 or 4 to 6 months, and then it starts fading. And then patients go to a stronger laxative, and that's when they start getting more and more problems, of course. So again, for constipation, fiber, Miralax, try to avoid stimulant laxatives.
Okay.
And then for diarrhea, that's a little bit different. We can group IBS patients more or less in 3 groups. So let me talk a little bit about that. There's IBS-C, where constipation predominates, and patients who suffer more pain and constipation, those are labeled as IBS-C. Then there's another group, about a third also. There's a third. There's about a third of patients who diarrhea predominates. And those patients also have pain, some bloating, but mainly present with diarrhea. And diarrhea can be anywhere from unformed stools to watery stools several times a day. And then the IBS, those are IBS-D. Then the IBS-A are the people that alternate diarrhea with constipation. Those are the more, another third of group of patients that are the hardest to treat. Okay, the patients with IBS-D or diarrhea predominant, there's a lot of new medications for it. So we can manage a little bit better, and also the newer medications for the IBS-C also. So we do have a lot of new medications we can treat as a doctor.
Well, so when somebody gets a diagnosis of IBS, whether they diagnose it themselves, whether they diagnose it with their gastroenterologist, how is their life going to change? Are they now going to be miserable? They can't go out. They're,
well, like I said, it's the second most common cause of
missing work, right?
Yeah, missing work in the United States. So it's very, very predominant in among women, and so yes, they could be miserable. I mean, literally miserable, because they can, especially if you have the diarrhea component. You know, you're in a meeting and all of a sudden you have to,
and it's not diarrhea that you can hold.
I have executives, that, I mean, big time executives in the board meetings, and they say, "Excuse me, I have to, excuse myself." I mean, that's limiting. It's a problem, and it could be to any. I mean, it doesn't have to be an executive. It could be anybody that works anywhere.
Okay.
But so it is. It can make a patient miserable. It could be that bad. But for that, there's therapies nowadays. We can control that and help it out. You're not going to get cured from this.
I was just going to ask that. You can't get cured. Not going to get cured. Will it get better as you get older? Will it get worse?
Sometimes it gets better with age, because people learn to modify their diet. They learn to use this and that. So it gets better in that way, that you're able to modify your diet. But again, there's no specific therapy there's not one therapy for everybody.
Wow.
So, but people will get better with time because of managing their diet. There's also a bunch of over-the-counter medication stuff that we're beginning to understand better, including the probiotics. So I didn't want to talk about it because probiotics it's an enormous field, and there's so many of them out there. The problem is that it's uncontrolled, and we don't have a specific delineation of what probiotic would work for X, Y, or Z person.
Oh, wow.
So we're still investigating this part, and we don't know an exact correlation between who needs what probiotic and do they work. Most societies that address IBS do not recommend, or cannot recommend, probiotics as effective, because they have never been proven to be really effective by data with scientific studies, etc. So yes, some people do get tremendous relief from them, but that has not been shown to be true for everybody.
For a large group of people,
correct.
Right.
So most societies do not recommend probiotics, even though many patients take probiotics to treat their IBS symptoms.
All right.
So that's it.
So we learned IBS is a constellation of symptoms. We learned that it could be diarrhea, could be constipation, could be an alternating form of diarrhea and constipation. The treatment is related to the symptomatology and what you're feeling.
Correct.
We know it's not curable. Now, will it kill you?
No.
It won't kill you.
It will not kill you.
Will it cause cancer?
It will not cause cancer. Very important. It will not cause cancer.
Okay. And you told us a couple of times, and I want to repeat this for our viewers. If you're bleeding, that is not IBS
at all.
And that you have to see your gastroenterologist and get a colonoscopy and so forth. Okay.
Same thing if you lose weight with the diarrhea, for example, that is not IBS. You have to look for other things, like maybe you have gluten sensitivity or food sensitivities, that kind of stuff. So not everything is that.
See, I think when you told me that I can diagnose IBS, there's no way. There's no way. Gluten sensitivity. Oh, no way. No. That's why I sent them to you.
Come on.
No. All righty. So again, does everybody need to see their doctor if they think that they have IBS?
The current thinking is no. Let's try to have patients, like everybody, every time you got a cold, you don't go see a doctor, right?
That's true.
So societies are trying to put the word out to the public. And that's why I'm doing this program today. Basically, try to bring it down to a level where the public can understand that some of these symptoms are could be self-treated and diagnosed. Like, well, I have a cold, and for the most part, patients will be correct in diagnosing themselves with a common cold. Correct?
Yeah.
Same thing with IBS. If you think you have IBS, be aware of the symptoms. That's what these community programs that you do are so helpful, because if you put the word out there and they can diagnose themselves with IBS and treat it with simple things like I said before, like try some fiber, try dietary changes, etc. We'll talk about more diet later on, but and you get better, then that's what you have. You shouldn't need to go see a doctor. Now, if you don't get better, or if you have some of the alarming signs, like I said before, bleeding, the unexpected weight loss, the alterations in laboratory tests, then you need to go see a doctor for sure. Or if you have a family history of colon cancer, got to mention that. If you have a family history of colon cancer and you have these changes in bowel habits, or if you have a family history of Crohn's disease or ulcerative colitis. And people know if they
they probably usually know that, right?
Right.
All right, so let's talk.
Right.
You were mentioning diet. I wanted to ask you about diet. So will diet change? And what about the diet?
Yes. There's a lot of investigations regarding how the diet changes our intestinal flora. Okay, and there's a lot of books out there and different things. I don't want to mention leaky gut because then I'm going to get another topic. So I don't dismiss patients when they ask me, "Do I have a leaky gut?" But it's very hard to prove that really exists. There's some degree of truth to that, but most patients do not have a leaky gut. But certain diets are helpful in IBS. A common one that has been proven to work very well is called low FODMAP, FODMAP diet. And you can look it up on the internet. There's certain guidelines you can follow. If you could follow that diet, it was basically developed in Australia. They were the first ones to really popularize this and to prove that it does work to release symptoms. Remember, this is symptom relief. So it's symptom relief. So if you want to say, well, what kind of diet can I follow to improve my IBS symptoms? Try that. Try the Flow FODMAP diet. Now, it's not easy to follow on a long-term basis. So most patients start and then they leave it after a couple of weeks, but at least it gives them some relief if it works for them. There are other diets that are obviously more specific. If you have diarrhea, obviously, then there's certain more complex carbohydrates that may give you more diarrhea, and milk products and stuff like that. There's an overlap of patients who have lactose intolerance with patients who have IBS. So that distinction you may need a doctor to make that distinction with some simple tests. But avoiding lactose and using the low FODMAP diet may be a way of self-treating yourself with a diet to try to relieve your symptoms of IBS.
Well, so we learned the FODMAP, FODMAP.
Correct.
FODMAP diet out of Australia. It's good. Can't be followed long. But you said avoid dairy. That would probably be the one thing.
Well, again, there's some patients think they are lactose intolerant, and yet what they do have is IBS. I don't want to say my wife was one of them. She thought that she was lactose intolerant most of her life, but when I tested her, she was not. She was really manifesting symptoms of IBS. So there's an overlap between true lactose intolerance and IBS. That's what I was trying to say.
And one thing we didn't talk about, we talked about constipation, we talked about diarrhea, we didn't talk about gas. How does gas play into all this? The gas that we have. And,
yes.
And tell us a little about, I guess, intestinal gas or colon gas.
Well, that's a fascinating topic because it's very difficult to study it. How do you trap gas, in the colon to investigate it? But everybody produces gas. And gas is produced by the bacteria. Again, I told you the intestinal flora, which is that group of bacteria that live in the colon, produce different types of gas. Most common gas is nitrogen and hydrogen, but bacteria also produce things like methane, which explodes, and sulfuric acid gases, which are very foul smelling. So the amount and the type of gas is directly related to the type of intestinal bacteria that you have. And everybody seems to have a different one. It's like a thumbprint. Okay. So everybody has a different type of bacteria. It is very bothersome. Many persons are very bothered by the bloating and the gas associated with IBS, more so than the alterations in bowel habits in some patients. That's where the probiotics are beginning to make some improvement in the production of gas, because if you overpopulate your colon with bacteria that do not produce gas, then you tend to have less irritable.
So we can do that? Can we, like we do with the bone marrow, clean out somebody's bone marrow with chemotherapy?
Yeah, well, actually, yes.
Can we clean out their bacteria and then give them another bacteria?
Yeah, we could. In fact, IBS, I don't propose this, but there's been some experiments using, as you know, fecal transplant to treat patients with severe IBS, because you're trying to give them a new flora, a new intestinal.
We're not really transplanting your stool, right? Clarify for our viewers. It's not like a lung transplant. We're not transplanting your stool with somebody else's stool and so forth. We're transplanting the bacteria, right?
Correct.
But it's called fecal transplant.
Right.
Wow.
Fecal transplant. So again, to that great extent, some of these nouveau therapies are targeting the bacteria in the colon and the gas that they produce, etc. So the answer is yes. It's a major component of IBS, and we're trying to modify it with either antibiotics that are not absorbed or with probiotics and other measures. Diet, of course, like I said, the low FODMAP diet. So
how do people control? So you talked about how to control your constipation if you have IBS-C, if you have IBS-D, how to control the diarrhea. Is there a treatment for that gas that people feel? Besides, because at home people can't remedy themselves with a fecal transplant and do all that stuff, right? So how do we manage the gas?
Well, the only options you have are some over-the-counter probiotics, like I said, or you could try some natural approach, like menthol-containing medications or caraway oil extracts. These have different salutary effects over the gut. So yes, I would definitely try most over-the-counter stuff. And if that doesn't work, then you're going to have to go to see a doctor. Then there's other options we have to try to control the gas. Gas is one of the most difficult things to control.
Wow. Yeah. No, even gas prices sometimes are difficult to control.
That's very difficult.
All right. So we learned quite a bit about irritable bowel syndrome. Let me tell you, I learned a lot myself. As a surgeon, I hear it. People say they have it. For me, it's not a surgical condition, not something I deal with, but I hear a lot of people have it, very common. And now I know it's the second most common reason for missing work. We learned that people can self-diagnose themselves and can almost self-treat themselves. You've reiterated a few times those warning signs of bleeding and change in weight. And if you have family history of cancer and so forth. And then, we learned about some more about gas as well. And we even talked about fecal transplant. So don't try fecal transplant at home. Please. But as we start closing, Pedro, tell us any remaining thoughts you have for our viewers, whether it be about IBS or a take-home message about their GI system as a whole.
Well, your gut is going to be with you your entire life. And it starts changing after we're born. 3 months after we're born, we start acquiring our unique gut flora. And a lot of things have to do with that. Many, many things. And in the future, we will have a lot more treatments that would allow us to change that flora to one that's not as irritable and as gas producing, as you said, as up to now. So that's my main message is for patients to try to diagnose themselves, treat themselves to the extent that they can. If that doesn't work, then of course seek appropriate expert opinions.
Of course, and get your colonoscopy at the age of 45.
45. We just changed the U.S. Preventive Task Force just came up with those new criteria. There's been over the last 10 years, there's been a significant increase in the detection of polyps, which have the potential of becoming cancer,
right?
From about 10% to 28% in the group of people between 45 and 50. So in the old days, there's only about 10% of people who would have polyps if you were screened them at 45 to 50. For some unknown reason, over the last 10 to 15 years, that has gone up to 28%. So that prompted a readjustment of when patients should start getting screened for colon cancer. Old criteria was 45 for people who have a high risk or if they were African American. Now everybody should start at 45 because of that increase in colon polyps. And by removing the polyps, of course, we can prevent
Cancer.
not all, but a lot of colon cancer. We can prevent, which is a key word in this. So this has nothing to do with IBS, but certainly great message to put out there. And
definitely.
And it's definitely get your colonoscopy at 45 if you can.
Wow. Great. And prevention, as we've talked about many times on Miami Community Health, prevention is the best treatment. IBS is not a condition that we can prevent, but you've learned a little bit about it today, learned how to treat it. Pedro, thank you for being with us today.
My pleasure.
Thank you for our viewers and our listeners for being with us here in Miami Community Health. And once again, Dr. Anthony Gonzalez signing off. Have a great day.